Thank you, everyone, for joining us for another Learning Lunch hosted by formatapproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is ICD 10 Deadline Deliverables, What is Expected? We're joined today by Dr. Evan Gwilliam of Find a Code. Dr. Gwilliam is a licensed chiropractic physician with extensive real-world experience in coding and ICD-10. He is a real talent for making ICD-10 easy to understand and even fun. So it's a pleasure to share his expertise with you today. Let's glance at the questions for today's session while I go over some quick housekeeping notes. Remember that you can ask questions of our presenter at any time during the session by entering them into the chat area. In the second half of our presentation, we'll address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, remember that all registered attendees of today's session will receive an email with links to both the slides and the recorded version of the event. All right, Dr. Gwilliam, thank you for joining us, and let's go ahead and get into it.
Great, it's a pleasure to be here. Thanks for having me.
So what's new with ICD-10, Dr. Gwilliam?
You know, ICD-10 has become hotter and hotter in the last few months as we've approached this deadline, and it's been in the news a lot lately. One of the biggest things I think you all need to be aware of is that they've added this concept of a possible extra chapter to ICD-10. So ICD-10 has 21 chapters which cover different categories or body systems. And there's been this proposal put forth just recently to add a 22nd chapter. And I've copied and pasted a patch of those codes here on your screen. And you can see there are Z codes. The first code that you see there, and there's several hundred codes in this chapter. ZA1 is the category of codes for certain infectious diseases caused by zombies. And then you have the subcategories there of allergic reactions to zombies, infections from zombies, and nausea caused by zombies. And just to pick one of these codes, take a look at ZA1.22, nausea caused by neighbors massacred by zombies. So, you know, one of the reasons we have ICD-10 is to make sure we cover everything. And so they thought that in the event of a zombie apocalypse, it would be useful to have codes that covered the potential health complications related to zombie-related incidents. And so I wanted to introduce you to this concept. You'll also notice at the very bottom of that list, this was released on April 1st of 2012 by Find a Code. So if any of you are kind of panicking or laughing or whatever, this is, all right, I just want to see if I could get you going. This is an April Fool's joke. There are no zombie codes, but they sure are fun to pretend like they're zombie codes. And if anyone would really like to see the full list, go to findacode.com. I think it's /April Fools, and we have every year we release some new codes like these zombie codes, and there's some fun ones that are available. So,
well, I think that's very funny, and you know, people fall for it a little bit, maybe for just a minute, because there are many different codes in ICD-10, especially like the external cause codes. There can be some funny ones in there, but not zombie codes, not at this point.
So there's somebody who's like logging in right after we said this, and they're going to go, wait a minute, there's zombie codes, and for those of you who are listening, they're not real, okay, but they sure are fun to pretend. There's not a lot of humor in the world of coding, and when you find some, you got to grab onto it.
Well, thank you, Dr. Gwilliam. Before we move on, I thought it might be useful just to briefly address sort of the big news in ICD-10. For folks who may not have heard, the Senate last night passed a bill that would delay ICD-10 implementation for another year. Could you give us your perspective on that development?
You bet. I am well connected in the ICD-10 world. I'm very involved. I travel every week to do training around the country on ICD-10, and so this is a pretty big deal. As early as last week, I taught a seminar, and I flashed up my slide that says, will it be delayed? And the answer is no. And I gave all these quotes from Medicare and all these resources that say it's not going to be delayed. It won't be delayed. There's no way it'll be delayed. And that very day, it was on Thursday, the House passed a bill. And that bill was designed to deal with some reimbursement issues with Medicare, and someone stuck in a footnote that said, P.S., let's postpone ICD-10. And because they wanted the rest of the bill to pass, and it was a last-minute patch, the bill passed the House on Thursday last week. And it had to be finished by yesterday, March 31st. So the Senate voted on it yesterday, passed the bill, It was designed primarily to deal with this SGR reimbursement issue with Medicare, but again, that footnote about ICD-10 being delayed for a year made it through as well. And it makes a lot of us look like fools, kind of, who've been telling everyone you got to scramble, you got to be ready, we only have 5 or 6 more months. But that bill says that Medicare may not enforce ICD-10 before October 1st of 2015. And that is no April Fool's joke. For those of you who haven't heard this yet, it looks like we have another year. So we have close to 18 months now instead of 6. And there's a lot of questions that have come about as a result of this that need to be answered still. And we simply don't know. And so I want to encourage you to stay in touch with Find a Code and Format Approved, because I think in the next few weeks we're going to find out how the industry reacts to all this stuff and find out what else we need to consider.
Yeah, and I was just going to add to that, it's important to note it hasn't actually been signed into law yet, although it's expected that it will be. Yes. Yeah. So yeah, a lot of developing kind of breaking news on this right now.
So let's kind of go forward and ignore those news for now and just let's all get ready. I mean, regardless of whether it's this year or next year, let's just get ready. And that's what we're going to do for the next 40 minutes or so, 45 minutes together.
And frankly, a lot of folks can use the time. So I think there's a lot of people who are behind. So this is an opportunity for them to catch up.
One of the things I like to teach in my training seminars is everyone should set aside a little time once a week to work on ICD-10. Well, I've been getting to the point where I said you need to dedicate 30 minutes a week, to study and work on ICD-10 and do some of the things that need to be done. But I think now that if we have another year, you can spend 10 minutes a week, maybe 30 minutes every other week. And so it just means that you'll be that much better prepared. So hopefully it'll end up being a good thing, regardless what the government says we got to do. So we might as well just press forward.
All right, Doctor. Well, let's get into it then in terms of what makes ICD-10 different for people who are used to ICD-9.
So this is a ton of information crammed into one quick answer. There are a number of important differences, and I think many of us on the coding side of things and health information management recognize the value of ICD-10 because of these differences. Our current system has some limitations. ICD-10 has a lot more detail and specificity, which means that there are codes for things that are unspecific, but we don't need them as often because we have much more specific options available to us. And that's going to make ICD-10 better for a number of reasons for tracking information. Also, ICD-10 is alphanumeric, so just the appearance of the codes means they're going to look different. They're going to have letters, and I'll show you some examples today. They are longer codes. They're up to 7 characters instead of 5, which is what we're accustomed to in ICD-9. Laterality is a new concept in ICD-10. In ICD-9, when someone had a condition of an eyeball or a kidney or an arm, there was only one code, but now there's 2 codes, one for each eye and each arm and each kidney. And so that's a new concept and one that I think ICD-9 seriously lacked. There's also a lot more combination codes in ICD-10. When we had a condition in ICD-9 such as diabetes, in order to code a condition that's a complication of diabetes, we had to use 2 codes. But in ICD-10, they created combination codes, which include 2 conditions that often occur together. And there's a great number of those that have been added to ICD-10. In ICD-10, we also have injuries grouped by anatomical site rather than type of injury, which makes that whole chapter much more clear. It's chapter 19 in ICD-10, and the structure is greatly revised and makes a lot more sense. Overall, the codes have been expanded and modernized. There were certain things that we knew about the human body, about physiology, that we had with technology and diagnostic methods that we didn't have available in the 70s when we were given ICD-9. And so those things have been adapted for and included in ICD-10. Overall, there's 21 chapters in ICD-10. In ICD-9, there were 17 chapters plus two supplementary chapters. And now there's 21 total. That includes the eye and ear chapter, and those 2 supplementary chapters got their own designation in ICD-10. The placeholder X is a new concept in ICD-10 as well. There are some codes that must have a 7th character, but they have no 5th or 6th character. So in order to report the code properly, we are instructed to put an X in those places. And those X's don't add meaning to the code. They just make sure that the 7th character stays put. And you can look at this example here, M1A.3120. It's a long code. There's 7 characters there. A couple of them are letters. The first 3 characters are considered the category, and they describe that this is chronic gout. I think it's M10 is acute gout. And then the fourth character, the number 3, tells us the etiology of this particular condition and explains renal impairment. There's a bunch of other M1A codes with a different fourth character for different etiologies. And then within that etiology, you can specify the laterality as well as the specific joint. And then the 7th character here tells us if it's with or without tophus, which is a complication of gout. So just this one example gives us a pretty good feel for how granular and specific ICD-10 codes are. And I think for those of us who are excited about better health information and greater detail, we think ICD-10 is a good thing. For those who feel like, oh, I have to figure this out, I have to learn these codes, I have to become fluent in them, that's a lot of work. And that's what I'm here to talk to you about today, is the deliverables about what is expected specifically of providers, but I'm going to start with everybody first.
So what will a clinic need to do to get ready?
So looking at everyone in a clinic, you can really break it into two groups. There's internal and external testing. And so with internal testing, this is where everyone in the clinic has to figure out these issues. And I think this may not be the job directly of the physician or the providers, but they certainly have to be aware of what's going on here. This may be the kinds of things they delegate to their office managers and their coders and billers. They got to look at software issues. And software plays a huge role in ICD-10. However, I want to point out that some people mistake that the software will solve all their ICD-10 challenges. And I've talked to plenty of software vendors who acknowledge that they can definitely help, but people still have to understand ICD-10 on their own. It's much like if I were to tell you that your Spanish-English dictionary will give you all you need to speak Spanish. In the end, though, you really need to know Spanish. And I think you need to know ICD-10. Your software isn't going to be able to know it for you. There's also workflow issues here. So the way that you communicate codes to one another in your office, the way the doctor provides the right information for the coder and biller to figure out, to submit on the claim, those issues need to be addressed, and that's all internal. When it comes to working with vendors, ICD-10 is like learning another language, and everyone has to speak that language. And so you have to be aware of what it is you need to ask them. There's lots of great resources out there. Medicare has some articles dedicated just to this topic, so you can probably Google those at cms.gov and look at questions and things to ask and talk to vendors about. Every form in your office that has ICD-9 codes needs to be updated. And internally, you have to figure out where those forms are and what they are and convert them from ICD-9 to 10 codes. We're going to talk extensively today about how to document for ICD-10. I'm going to give you an example later. And so your EHR templates play a big role in that. And I believe if someone can get in there and figure out what the codes say and what they want, and then condition those who are creating the documentation, the providers, to match up what the codes are looking for, it'll smooth the process out quite a bit. And so those templates used within the EHR need to be revised to satisfy the criteria for those ICD-10 codes. And then it's also important internally for the staff in an office to watch what payers are saying about ICD-10, especially now. For example, Medicare has assured us that they would release updated LCDs which contain the ICD-10 codes for each specialty that they're going to accept by April 10th. Well, that's 10 days from now. I don't know if that timeline is going to change because of this new delay. But that's just an example of one of the payer notices you should be watching for, was Medicare's list of acceptable ICD-10 codes. And there's plenty of others coming out from the private payers as well.
So that's sort of the internal process. What is some external testing that a clinic will need to do?
Well, you know, if you have all your ducks in a row, yet your partners that you do business with don't, it's going to create some major headaches. And so I think it's important to recognize that it's important to look at any transactions that occur outside the clinic with parties outside the clinic. They need to be tested to make sure that they work and they flow. And the good news is we might have a little more time to conduct that testing now. Medicare launched some of their testing just this past month at the beginning of March. And I haven't seen the results of that yet, but they said based upon how those tests went through, basically what they did was they accepted practice claims from various providers, and then they ran them through and decided to see if they worked. And based upon that, they announced they were going to do more specific testing and give more specific feedback. That might get bumped, but that's an important part of this process. I think that you need to make sure that you are able to use your EHR to communicate through your clearinghouse to your payers and make sure that everyone can handle the information, it can pass through, even if the claim can actually be processed. And I was recommending that that needs to be done by the end of this summer. that you should have contacted your clearinghouse, you've worked with your software vendor, and you've talked to a payer like Blue Cross, and you will hopefully have sent a practice claim all the way through the system to make sure it all can work and there's no bumps in the road. And so that is a process that maybe can be delayed for a little while, but it's still an important piece of this process. And I think one of the last things an office needs to do and be aware of in the clinics.
So you mentioned before, that there's different people impacted by ICD-10. Tell us a little bit about how people in different roles will be impacted.
So if my job is a researcher, whether it's scientific research or I'm a government worker and I gather data for policy making, I'm going to have better data. ICD-10, I truly believe is essential for healthcare reform. I think in order to improve our healthcare system, we need to have better information, and ICD-10 can provide better information. And so for researchers, they're happy about ICD-10. It's going to make their job better and easier. Billers and coders have a number of considerations, but one of the biggest challenges will be what codes are the payers going to want? And this is one of the biggest concerns with ICD-10 is what do the payers really want? How do we know which codes are going to be appropriate? We've been using ICD-9 for so long that we've kind of dialed it in, and we know what they want and what they don't want and how they expect the codes to be used. But billers and coders are the ones who are stuck in the middle. They have to bridge the gap between the providers and these payers, and it's a hard place to be because there's just a lack of information there. There's unwilling providers and there's payers who haven't told them anything, and they have to make everyone happy and make sure everyone still gets paid. And that's a very important role. There's the payers who, it's an up and down for them. In some ways, having more accurate diagnosis codes means that they can make sure their providers are doing their jobs well, and they can deny payment if indeed a provider is not providing a correct diagnosis or being sloppy in their ICD-10 code selection. But I want to point out that that doesn't mean you're going to get paid less. It isn't just an excuse for denials. For those of us who have gone through the trouble to get trained and learn to speak ICD-10 fluently, I believe that you can use it to protect yourself from audits and to keep payers from denying claims, because if you're communicating clearly to them and you know what you're saying, it will make sure that you ensure that your claims are medically necessary. And so even though at the bottom of my list here, physicians are going to have to learn these new codes and work on documentation, yes, this is going to be extra work, and it's going to take you away from patients to a certain extent, but I don't think it's unfair to ask providers to do a good job. And if providers provide clear information about what's wrong with the patient, I don't think it's going to be this huge burden to learn. I think that with a little bit of effort, with training like this, it can be done. And at the end of this little webinar, we'll give you some other resources. But the biggest challenge for providers really is figuring out what codes are available to them and then figuring out how they must document to meet the criteria to satisfy those codes. And that's what I want to spend the rest of this hour talking about, is really how's it going to affect the physician themselves? What deliverables do the physicians have to be able to say, I'm ready for ICD-10, I've got it in place?
So for providers, how is documentation going to change then around the transition?
Well, for starters, I want to make it clear that if you read the guidelines within ICD-10, it says specifically that you may not choose a code that is not supported by the documentation. So I think some providers may be out there and they want to be a little lazy on this or cut some corners and say, you know what, my coders will figure it out. They'll just figure out what codes the payers want and they'll use those codes. And it's not like that. It simply can't be done. You must learn to document to support the codes. And if that is done properly, then the claims should be processed correctly and you should get paid. Now, there are some new concepts that providers need to be aware of in ICD-10. And just to give you a few examples, some of the hemiplegia codes on paralysis in the nervous system chapter of ICD-10 include information about side of dominance. In other words, the code you pick is dependent on whether or not the patient is right-handed or left-handed. And you didn't need to document that for hemiplegia codes in ICD-9, but you do in ICD-10. For those of you involved in wound care, the codes for wound care include information about stages of healing. That was not required in ICD-9, but it is in ICD-10. That's a new concept that must be documented by the providers, or else the coders can't choose the correct code. Trimesters is new. For those of you in obstetrics, every single obstetric code or pregnancy code now has 3 codes, because there's one for the first trimester, one for the second, and one for the third. And that concept didn't exist within ICD-9, and that's just an example of why there's 3 times as many codes, at least in that group. Laterality is a huge change in ICD-10. It's going to affect many specialties, As I mentioned earlier, if you have two body parts, there's now two codes for those parts. Anything you have two of, a right and a left, there's a right and a left code. But I think from a documentation standpoint, it is not hard to document that. For example, if a patient had sciatica down one leg, I believe that most providers already document right or left sciatica. Or if a patient had a fractured arm, they probably already document right fracture or left. And so it should be easy to get this concept, and it won't require extra work on the part of the providers. Despite that, I really encourage providers to go in and look at the codes that they use and figure out, looking at stages of healing, for example, and recognizing that those are things that they need to become familiar with those codes so they know what they need to do to document. The last concept I want to mention here is ordinality, which is the concept of encounters. A great many injury codes, which is the S chapter or chapter 19 of ICD-10, includes information about the initial encounter or subsequent encounter or sequela. That concept is new to ICD-10, and it didn't have to be documented to choose the codes for ICD-9. And so it's important for providers who are dealing with these codes to understand the difference between those concepts so that they can code it properly. So none of these things had to be documented to support ICD-9, but they do have to be there for ICD-10.
All right, so let's look at an example of what the documentation looks like and how it relates to the codes.
Great. So what I've done here is I've taken the assessment portion of a SOAP note, and I've come up with what the ICD-9 codes might be. So the note says exam findings are consistent with cervical sprain strain and acute cephalgia due to motor vehicle accident. So somebody was in a car accident, they hurt their neck, and they have a headache as a result. Okay. In ICD-9, the codes might look like this: 847.0 cervical sprain, 33921, which is acute post-traumatic headache, and then an E code, which is an external cause code, which describes what the patient was doing or where they were during the accident. External cause codes are not required by most payers, and many of you may be unfamiliar with them, but on ICD-9 they start with a letter, and they describe what the patient was doing or where they were when they were hurt. These are greatly expanded in ICD-10, and crosswalking to them is a real challenge because they really can't be crosswalked. They have to be brought up on their own. So what I'd like to do is take you through several steps to look at, first, what are the new codes? We need to know what the codes might be in ICD-10. Then we're going to go back and look at this short note that I wrote and rewrite it to satisfy the criteria for those new codes. So let's start with 847.0 cervical sprain and look at the different ways we can try to find the new codes for cervical sprain. So we can start with GEMS, and I'm going to hope that many of you on the call today are already familiar with GEMS. Rather than explain what it is, I'm just going to jump in and start using it. So GEMS tells us that the replacement codes for 847.0 and ICD-10 could be S13.4XXA or S13.8XXA. Right, and that's very helpful. We have a start. We have some codes that might replace it. The question now is, well, how do these codes differ? And so when you look up S13.4XXA in the tabular list of ICD-10, you'll figure out that there's a bunch of fine print under it or extra instructional notes that explain which parts of the neck are considered appropriate for this code. And then when you compare that to the other code, you'll find out it covers other parts of the neck. So in order to properly select the code, you have to know what the fine print is below that code. And that is one of the challenges of ICD-10. Too many people in my trainings have said, just give me a list of a couple dozen new codes and I'll use those new codes. And the truth is you have to understand what's behind those codes to make it work. You have to understand the guidelines and the instructional notes. When it comes to GEMS, just so you know, you can go on your smartphones and download a free app. We've taken the government database and plugged it in, and you can access that. Many of your software vendors should have it built in by now. Your EHR vendors are going to have the GEMS as part of their software package as well. So that's not the end of the story. GEMS gave us a couple of codes it could be, and our note didn't really tell us enough to differentiate between those two codes, but there's more, because it turns out that sprain codes in ICD-9 included strain, but in ICD-10 they do not. Therefore, if you wish to document a sprain as well as a strain in ICD-10, you have to find another code. This code is S16.1XXA. It's strain of muscles of the neck, and the only way we found it was well, there's two methods that I've come across. One is we use the alphabetic index to search for other options. The other is using the excludes to note from the other code. which we can't really get into in this short format today, but I find that using excludes to notes in ICD-10 can be very helpful in helping you determine if you need an additional code. Excludes to essentially means not included. So what that means is when we look up sprain, it says excludes to strain. So we know strain is not included, and it gives us the code, and we can go look up that code and see if it's appropriate in that case. And so it's very important to understand the alphabetic index and how to use these guidelines within ICD-10. So looking back at our note, remember we've got our little note here. We've got the second code, which is acute post-traumatic headache. Now we want to investigate this code and see what the replacement might be. Okay. Now I haven't decided on the replacement for the sprain code just yet, but I will. First, I want to look at the options for this second code, and then we'll look at the options for the third, and then we'll come back and I'll show you the codes I've selected, and then I'm going to rewrite my note so that I want to help the providers on the call learn how to redocument according to the codes. So if we look up 33921 in GEMS, which is a code mapping tool provided by the government, we will see that there is just one option here, and it is G44.319, acute post-traumatic headache, not intractable. Almost the same. Except it has this little bit about intractable. Well, for some of us, we may not even know what that word means. And so providers who are looking at new codes with information that they may be unfamiliar with, I encourage you to keep your medical dictionary nearby, and you might have to look stuff up. Intractable literally means hard to control or deal with. So in ICD-10, it turns out that a lot of the headache codes have an intractable option and a not intractable option. And the GEMS suggests the not intractable version, which actually, if you look up the code, it says also is unspecified. But if we look nearby, we find G44.311, which is the intractable type of this headache. So that would be the one that doesn't respond readily to treatment. It's the persistent tough headache. But the 319 is the one that does respond to medication or to treatment. And so in my note, I didn't have information about whether or not this was intractable. And so that's something I'll have to change for ICD-10. So looking at our note now, at the end we had motor vehicle accident, and that allowed us to choose the code E813.0, which tells us that this individual was in an accident that collided with another vehicle. Let's see what the options are for this particular code. This gets tricky because this is an external cause code, and there are no GEMS mappings. We can't use that GEMS tool, that little shortcut, to help us get closer. And so we have to do something else. External cause codes are not injury codes. They describe the mechanism of injury, the location, the circumstances, or the cause. And my note simply didn't have enough detail for me to pick a new code. And I want to remind you, however, that external cause codes are not required. There's no national standard for these. However, Medicare has said they encourage us to use them because they provide great information about how people are being hurt, which could be used to decide who to blame and bill for an accident. It might also be used for public safety issues. So let's see what we have here. Here's the new note. All right, so this is the note rewritten to meet new criteria to satisfy the codes I selected. And here are the codes that I've selected. I ended up with 5. Okay, so what I'd like to do is take you through each one of these and show you how I changed my documentation to support the codes that I found using GEMS and the alphabetic index in my tabular list. So that first code there is sprain of ligaments of the cervical spine. And you'll notice that in the note, I just changed a little bit to make sure that the wording matched the code. One of my roles with Find a Code is I'm an auditor. I do records review, and I'm a certified professional medical auditor. And some of the advice I give to our clients is learn to document to support the codes. So you'll notice that I didn't change the meaning of what I said, but I changed the wording to match the code. So it's really easy for an auditor to say, yep, that's the right code. The next code I picked was the strain code. Remember, sprain and strain are different. They're separate in ICD-10, and they weren't in ICD-9. So I made them a little separate here in my note. I made it clear that there was strain of the muscles of the cervical spine, which matches most of the words in the actual code itself. And then we go to the headache code. For the headache code, I added a whole phrase which says, which does not respond to over-the-counter medications. So what we're looking at there is I added information to help me determine whether or not the headache was intractable. And this is a practice case, so I would definitely say don't go back and change notes, real records, but pull a real record and use it for practice. And in this case, I decided to say that this patient's headache was indeed intractable. Remember that the GEMS map suggested a not intractable code, but I'm going to stick with intractable because I went ahead and added it to my notes. So I'm going to condition myself in the future, next time I have a headache patient, to document that information so that it becomes second nature to me. The last two codes I chose are external cause codes. the first one is a V code, which tells me these are traffic-related or transportation accidents, or V codes. The driver was injured in a collision with an unspecified motor vehicle. So I went ahead and made sure that my note specified that the person was the driver, they collided with another motor vehicle, and I included all that in my note to support the code so that they matched up really nicely. And then my last external cause code here is a place code. That was not information I included in the note initially, but I added this to say that they were on the interstate. And so I've chosen a place of occurrence code that tells me where they were. Now I'm not done. The last little line here in my documentation is that he was not treated at the scene. So this bit of documentation helped to establish why I chose the A as a 7th character on the codes that required it. There were 3 codes in this case that required a 7th character extension that describes the encounter or the ordinality of the visit. And so I wanted to be very clear why I chose the letter A. The letter A means initial encounter, and I selected it because the patient was not treated anywhere else. This is clearly their initial encounter for this condition. And I wanted that to be very clear. Now the concept of encounters and the use of these X placeholders for these codes and so on is another topic that we can talk about another day. The purpose of this webinar wasn't to teach you all the basics, but to start to help you look at some of the deliverables for these doctors and the documentation they'll need. So in the end of the day, I took my note, I made it twice as long. I have 5 codes instead of 3. This is just one example. And I strongly encourage providers to do something like this, to get used to their own notes, take their own notes, find the new codes, and rewrite their notes to match those new codes as practice as we build up to this ICD-10 transition. One of the concerns that the doctors have is suddenly I'm going to have to do all this extra work. You know, the AAPC suggests that it's going to take 15% longer to do documentation. Well, I'm going to suggest you should spend that 15% longer now instead of waiting until after the implementation date. If you can do that now with your codes and with your claims, you're going to be much more prepared when the time comes because you're already going to be doing it. You're going to have built it up until that date, not waiting until that date to suddenly change.
Well, that was very helpful. Thank you, Dr. Gwilliam.
Mm-hmm.
So what are some myths about ICD-10 CM? There's a lot of them out there.
There are, and I think there's going to be more flying around because of these recent legislative changes. But there are a few here that I think are worth mentioning because these are common questions we get. And those of you who've been putting in your questions, keep doing them, but I think we may address a few of them right here. So, you know, one of the myths about ICD-10 is when it does implement, is it going to cause everything to just shut down? Is it going to be the end of the world? You know, some of you remember Y2K and December 21st of 2012 with the Mayan calendar. Those are supposed to be the end of the world. You know, we made it through those dates. I think we'll make it through this one too. It's going to be a challenge when it does happen, but it's going to be survivable, you know. Now, you may have heard that workers' comp and auto insurance will not be required to use ICD-10. That is true. That's not a myth. That is actually a fact in that they are not subject to the HIPAA regulations, and HIPAA is the law that enforces the implementation or use of ICD-10. And workers' comp policies, auto insurance policies are not required to move to ICD-10. However, you should know that I hang out on the street corner with other coders, and the word on the street is that they will switch. If you were to call up your state workers' comp or you know, a big auto insurance holder like State Farm or Farmers, I almost guarantee you they're going to say, yep, we're going to move to ICD-10. Or they haven't decided yet. But I don't think they're going to stay with ICD-9 because it's going to be too hard to do business if they do something like that. It makes it too hard to communicate with the rest of the healthcare system if everyone else is switched. I have heard, let's see, I was speaking in Washington State last week, and they got a letter from their state workers' comp making it clear to everyone that they'd be using ICD-10. And when you look at some of the external cause codes available, I think it makes it great for workers' comp. It's going to make it easier for them to collect data they need to understand what's going on. Another myth is that Medicaid won't be required to be ready because somehow they aren't impacted, but Medicare has assured us that Medicaid will be ready. They're going to have the same help and guidance from Medicare that Medicare has created for everyone else. Now, some have speculated that ICD-10 is so large that it's unmanageable. The number of codes make it impossible to use. Well, the response to that is that, you know, a dictionary that is small and can be useful, but a dictionary that's huge is more useful. The more words in a dictionary, the better. And ICD-10, because of its size, is better. It's not indecipherable. It's actually quite logical, and it's going to take some effort and time to learn and understand, But once you understand it, you'll see that it really is a better system than ICD-9, and it will improve the way we report information. Another myth or concern about ICD-10 is that the documentation requirements will make it impossible to use, that we'll have to document all kinds of frivolous and wasteful information which simply takes time away from taking care of patients, which is what most of us got into healthcare for in the first place. And there is some truth to this. I mean, we're going to take longer to document. That's true. We're going to have to learn how to document for ICD-10. However, I think it'll become second nature eventually. I think many of us, those of us who've been in this field for a long time, remember the ICD-9 transition and felt like it was too hard and decided to retire and get out. I think that ICD-10 documentation requirements will be a challenge. They're going to take some time, but it's just part of doing business, and we have to learn to document a little better if we don't document well enough already. The AAPC did do an audit of a bunch of doctors' records and determined that over half of them weren't good enough for ICD-10 yet, and so it certainly is going to require some work. Now, ICD-10 was delivered to us in the early 90s, and some would argue that since it was given to us 20 years ago that it's no good anymore. It's out of date. We need to move on, or just wait for the next big thing, which is ICD-11, by the way, which will be available next year, but that's another story for another time. We may be using ICD-11 by the end of the decade or shortly thereafter. ICD-10 isn't really out of date because it's been updated once a year since 1994, all the way until 2011. And then in 2012, the codes were frozen to make it easy for us to transition. That was back when we thought we were going to transition in 2013. So the codes, if any of you bought code sets or you purchased products with printed codes in it, they haven't changed since 2012, and the codes are good. And I tell my clients when I'm teaching them that the codes are good until 2015, which is when they'll update the codes again. That information may change with this delay. But ICD-10 is current as of 2011 when it was updated last. And so it really has kept up pretty well. We'll have to wait and see what they do with it in the next year. And then the last concern that some people have is will CPT codes be replaced by ICD-10? ICD-10-PCS is a procedure code set in addition to ICD-10-CM. It has another 80 or 90,000 codes, and it does indeed include procedure codes, but we are instructed they will only be used in a facility setting. So CPT codes will continue to be used by doctors in an outpatient setting, which is in a typical clinic, and also outpatient in a hospital. But if it's inpatient in facility, then those PCS codes become relevant, and we haven't talked about those at all today. That's a subject for another time, and for those of you involved in inpatient coding.
So what should providers do to get ready now?
So, you know, the answer to this question changed in the last couple of days. But basically, I think it's critical to start training. If I were to offer you a free trip to Mexico and say, you know what, I will send you to Mexico, but here's the hitch. It begins October 1st, and you have to show me before October 1st that you can speak Spanish fluently. You would not wait until the end of September to learn Spanish. You would start now and begin working on Spanish and become an expert speaking Spanish. So I think it's important for any office to establish a formal training to make sure there's a plan in place where you begin working on this new language right now instead of waiting until the last minute. And I think that for coders, they're going to have to be familiar with those codes and learn the anatomy involved. If you aren't very savvy with anatomy, it may be a good time to brush up. And it may be nice to have this extra year to learn that. The providers, the biggest challenge for them is the documentation. And I think I presented one way you could work on how to document in your office with your own notes. Budgeting is a big deal. And depending on who you ask, it could cost anywhere from $4,000 to $40,000 to move to ICD-10. That includes things such as software upgrades, down to paying for training, and then in the back end, dealing with the possible claim delays and denials as everyone makes this transition. And so that number varies depending on the size of your clinic. You can also start by building your own super bill or your own crosswalk. Take the codes you use most commonly in your office. Run a report of the top 20 or 30 codes and take each one and use that GEMS tool, such as the one you can download from Find a Code, or just Google it, you'll find it, and start looking at what the new codes might be. Just keep in mind that GEMS is only a starting point, it's not a finishing point. Okay? It takes you close to the code, but you have to investigate the code set itself and then figure out if the codes are appropriate and follow the guidelines. Look at everywhere in your office where you have forms. Anywhere you have codes within your office, which could be forms, could be even contracts, your website, anywhere where you might include diagnosis codes, they need to be updated. So make a list and try to figure out where those things are and begin to, it may be premature to actually replace those codes, but it might be wise to go ahead and figure out what those codes are and have them kind of stored in the background. I've been working with a number of EHR vendors, and what many of them have done with regards to ICD-10 codes within their system is allowing people to put in ICD-10 codes on real patients right now, but they exist in the background. So they don't show up on a claim just yet, but they can build the codes into the system, and then the system will switch those codes out on the day of transition and put the ICD-9 codes in the background. They bring the ICD-10 codes to the forefront, so they're the ones that end up on the claim form. And if you can begin to research what those codes are and put them in your software, then you'll be ready to go on the date of transition, and hopefully the doctors will have learned how to document to support those codes as well. And then one of the other things that you should consider is contacting your vendors. Primarily software. There's a lot of software concerns here, so you should reach out to those vendors, your clearinghouse as well, and talk to them and say, okay, when can I do a test claim? What are you going to do with me? How can we work together to make sure this is going to work? Because if I'm using a 7-character code with letters in it, how do I know your software is going to be okay with that and not deny my claim just simply because of processing issues? And so you'll want to speak to them and reach out to these vendors and make sure that you ask them the right questions and make sure that they are ready to go. That's your external testing that I mentioned earlier as we were talking about some of the steps that you should take within your clinics.
So where can providers learn more information?
There are a number of great resources out there, and some of them will cost you a lot of money, and some of them are relatively inexpensive. Let's start with Medicare, because it's free. You can go, and Medicare has done a terrific job of putting out a ton of information about ICD-10. In fact, as recently as last month, they said, you know what, we've worked hard, we're ready to go, everyone else will be ready, we've given them all that we need, we're going to do this for sure, there's no date delay. And then Congress kind of trumped them and threw out this little surprise, but Medicare has got lots of great information there. I recommend you sign up for their email updates if you haven't already.
And just so, I was just going to say, just so folks understand, we've abbreviated the URLs. It seems like every CMS URL is this big, long gobbledygook, which is kind of hard to show on a slide anyway, but you'll all receive a copy of the slides after this event, and you'll be able to just click on the link, and it'll take you right through to sign up.
Yeah, and there's always Google. You go to Medicare, ICD-10 email, you'll find it. This CMS Myths and Facts is a great resource. It's like 2.5 or 3 pages long, and it's just a quick Q&A about ICD-10, and I think it's nice because Medicare, when they answer the questions, were very brief, and whenever Medicare is brief, you should grab onto that. So Medicare has lots of great stuff. Find a Code is the company that I work with, and we have lots of great tools. We'll show you how to sign up and get a free trial and go play with that. We've worked really hard to have all you need for ICD-10 and be ready by this year. So if you start now, you'll definitely be ready by next. ICD-10monitor.com is a terrific resource for free articles. They get industry experts on their editorial board, and they write articles for them. I'm on their editorial board as well, and I've been interviewed on Talk 10 Tuesday, which is a talk show that they host once a week, a webcast, if you will. And it's very well done, and it's very brief and gets right to the point and hits various topics with regards to ICD-10. I strongly encourage you to, if you're involved in your organization in implementation, you should listen to these Talk 10 Tuesdays. They're great resources. And I've been on it a couple times. And then perhaps you'd like to talk about the Format Approved training that you guys have available.
Yeah, just really briefly, we offer 2 essential flavors of ICD-10 training because the needs of folks are different depending on what their role is. So the first link there will take you to our course that's designed for coders and billers, and that is really a bridge course from ICD-9 CM to ICD-10 CM. The second link is the course designed for providers, and that really focuses on documentation. There's a version that covers 16 different specialties, and then there's individual specialty versions if you need to look at that. And I'm going to mention this again in just a moment, but you can get a 20% discount off of those courses by using the Find a Code discount, which is FIND20. Using that discount code will take 20% off. And you can continue, Doctor.
Excellent. So I listed a couple of the resources at the bottom because I'd be remiss if I didn't mention them. There's the AAPC, which is the American Academy of Professional Coders, and there is the HEMA, which is the American Health Information Management Association. And let me just say that these guys are the national leaders in this stuff, and they offer all kinds of certification. If you want to go there, they have some really expensive training. So if you're looking to spend money, this is a great place to do it. They have and I've spent lots of money with them getting my certifications and training over the past couple of years. So just know that they're available to you as well, but I believe there are some more cost-effective methods that we've already talked about.
All right, well, we've gotten to the question and answer period of our session today. So we've already got a number of questions from folks. If you've been saving your question, you can go ahead and enter it into the chat area now. We don't have a lot of time. If we run out of time, we'll be aware that we're going to save those questions. We'll send them on to our presenter, and he will give you written answers to those, which we can share with everyone. But let's go ahead and get to the questions. Here's kind of a funny one that I think is worth answering, though. This is a silly question, but does it matter if the placeholder X is lowercase or uppercase?
It actually is a fair question. I've heard that one before. What I've come across as the official rule is it may be either. However, many printers and publishers have chosen to go with lowercase to make it more obvious. And most of the other characters, the alphabet characters, are all uppercase. However, I believe the official rule is they could be either or. So what we suggest is keep them all uppercase except for the X. Make it lowercase just so it stands out. But there's no requirement.
All right, let's ask another question then. And this is, I don't understand why billers need to know which codes the payers prefer when the doctor has a specific diagnosis based on the new ICD-10 codes. Where does the preferred code come into play?
Well, let me give you an example. There's some codes on, for example, on stenosis in ICD-10, and there are some codes towards the end of the M chapter that have specific types of stenosis. And then there's some codes in the middle of the M chapter that are more generic stenosis codes. And it is possible that payers will set up a policy that says, we only like the stenosis codes that are more specific, or we don't care for those are too specific. We want you to stick with the general ones. That's good enough for us. And the doctor may document that supports either code selection. And so the coder needs to know which ones the payers are have written their policies around. There are a number of codes in different specialties that. So let me say this: I believe that you need to pick the codes that are supported in the documentation regardless. But you also need to be aware of what the payers are looking for, because some of them may require external cause codes, for example, and some of them may not. And if you don't know those policies, then you may not be able to get paid properly. So always only code what the doctor documents, but make sure the doctor knows what the payer's preferences are or what their policies are around those codes that they've selected.
So I think for this one we may have a misunderstanding, but I'll let you address it. The statement from the attendee is, you said that workman's comp and auto insurance will still be using ICD-9. Are you saying that the CMS portals will always accept ICD-9? What exactly do you mean that it'll stay with ICD-9?
And I probably should have phrased it differently on the slide. They are not required to transition to ICD-10 because the law that enforces ICD-10 on the rest of us does not include them. And so, but they will switch. So you need to be able, possibly, you need to talk to these payers and see if they didn't switch, because they don't have to, and be able to submit ICD-9 codes on claims to them, but ICD-10 to everyone else. That's a possibility. But I think they'll switch, and it won't matter. We should do ICD-10 with everybody.
Are there different ICD-10 code sets based on your type of practice?
So the short answer is no. There's ICD-10-CM and ICD-10-PCS. And the difference there is ICD-10-CM is for outpatient setting, which is what you submit on a claim. And then there's ICD-10-PCS, which is for statistics in a facility setting. So for those of you who might be in that setting, yeah, there's a different code set you need to learn about. But there's not a specific, a code set for obstetricians and one for, oncologists and that type of thing.
But obviously there's codes that are probably going to be used a lot more depending on what your specialty are. And
exactly.
That's one of the things about the training that we mentioned before, is that by breaking it down by specialty, that helps people sort of focus on the documentation concerns that are most important for them. So if you're a gastroenterologist, the documentation cheat sheets that we have in the training that I mentioned before focus on what you need to know to get the documentation right for gastroenterology, which is obviously got a little bit of feedback there. But That's obviously going to be different than if you're an OBGYN, for instance. All right, let's ask another question, although we're getting short on time. We have to end just a little bit early today. Will vendors provide the option of submission of either ICD-9 or ICD-10? Oh, this is a follow-up to the workman's comp thing. So if the workman's comp doesn't switch, will you still be able to use ICD-9 and ICD-10 in the software, or is that going to depend on the software?
That's going to depend on the software, but the ones I've talked to said they'll make sure you can do either if you need to. So it should have the ability to choose which codes you're going to use on that claim.
All right. Well, we've got a few questions left, but as I was saying before, we're going to save those, and we'll assemble all of the questions, send them on to our presenter, and then Dr. Gwilliam will be able to write answers to those. We'll post those on our website, and we'll send emails out, and you'll be able to look at the written answers, so then everyone can share the knowledge together. Great. And I'd like to mention to the audience that everyone who registered for this event, whether you're able to actually attend or not, will receive an email with links to both the slides and the video recording of this session. So look for that follow-up email with the answers, the slides, and the video. I'd like to thank you, Dr. Gwilliam, for joining us today. It was a really great, lively session. You have a real talent for making ICD-10 easier to understand.
I appreciate that. Thanks for having me.
To sign up for a free 2-week trial to use FindACode's coding tools, which Dr. Gwilliam mentioned earlier, please visit www.findacode.com. I've used these tools myself, and I can say with no exaggeration that they're really incredible. To take just one example of many, the Build a Code tool that you'll find there is a great resource just for understanding ICD-10 because it lets you see how the codes are built sort of character by character. But there's a number of different tools in there that you'll find useful. So do take advantage of that free trial on those tools, and it might make it irresistible for you to use FindACode for answering your coding and billing questions over the longer term. As I mentioned before, if you are interested in ICD-10 training for either coders or providers, you can visit www.formedtraining.com. If you use the discount code FIND20 at that URL, you can get a 20% discount off of that training. Visit formedapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button will take you to our upcoming webinars where you can learn more and register. Our next Learning Lunch will air April 8th, and we'll cover the subject, Online Storage and Backup. What does secure really mean? Keep an eye on your email box on our homepage for other upcoming Learning Lunch topics, and thank you again for joining us today.